Welcome to today's presentation, where we're about to embark on an intriguing journey into the realm of metastatic breast cancer treatment, focusing on a novel approach, low-dose metronomic chemotherapy. This approach has been making waves in the field of oncology over the past few decades. Unlike traditional high-dose chemotherapy, low-dose metronomic chemotherapy involves the continuous administration of cytotoxic drugs at significantly lower doses. Today, we'll dive deep into the principles behind this innovative strategy, explore its potential advantages, and examine how it can be applied in the context of metastatic breast cancer. By the end of this discussion, you'll have a comprehensive grasp of this evolving treatment method and its vital role in the ongoing battle against breast cancer. So, let's jump right in.
Let's begin with a discussion on breast cancer. Clinical experience in the field of breast cancer has highlighted its prominence as one of the key areas for metronomic therapy. The rising number of patients facing incurable metastatic disease, necessitating palliative treatment, coupled with the cumulative toxicity associated with traditional cytotoxic therapies, has prompted a focused effort to explore alternatives to conventional treatment regimens. This includes drugs such as taxanes, anthracyclines, pyrimidine antimetabolites, and tubulin inhibitors. Among the candidates for metronomic therapy, cyclophosphamide and methotrexate have emerged as prominent options in the context of breast cancer. Earlier studies delved into the oral metronomic administration of cyclophosphamide and methotrexate in combination for pre-treated metastatic breast cancer patients. Notably, Colleoni conducted research involving a daily dose of cyclophosphamide at 50 mg along with methotrexate at 2.5 mg twice daily for 2 days per week. This approach yielded an objective response rate of 20.9% and a clinical benefit rate of 31.7%. In the long-term follow-up, a subset of these patients achieved a prolonged clinical benefit, extending beyond 12 months. Furthermore, the combination of metronomic cyclophosphamide and maximum tolerated dose liposomal doxorubicin was assessed in metastatic patients, resulting in a clinical benefit rate of 75% and a median overall survival of 6.4 months. More recently, a study in pre-treated metastatic breast cancer patients examined the combination of metronomic cyclophosphamide and methotrexate. The median progression-free survival and overall survival were found to be 5 and 7 months, respectively, with 1 patient out of the 48 enrolled achieving a complete response. In a Phase 2 study, researchers conducted an assessment of the safety and efficacy of metronomic oral chemotherapy in patients with hormone receptor-positive metastatic breast cancer. A total of 43 patients in the treatment-naive group, and 65 in the pre-treated group, participated in the study. The treatment regimen consisted of vinorelbine, 40 mg thrice weekly, cyclophosphamide, 50 mg daily, and capecitabine, 500 mg thrice daily. In the treatment-naive group, the median TTP reached 25.1 months, whereas in the pre-treated group, it was notably shorter at 11.2 months. Among the reported treatment-related adverse events, grade 2 leukopenia and hand and foot syndrome were the most frequently observed. In summary, the metronomic combination of cyclophosphamide, capecitabine, and vinorelbine demonstrated significant activity and exhibited good tolerability, particularly among patients with hormone receptor-positive metastatic breast cancer. Shifting our focus to triple-negative breast cancer, it's crucial to acknowledge the limited availability of data concerning the benefits of metronomic cyclophosphamide, capecitabine, and vinorelbine as the initial treatment for patients dealing with metastatic triple-negative breast cancer. In a Phase 2 study, investigators thoroughly explored the safety and effectiveness of metronomic oral chemotherapy. This involved the administration of vinorelbine, 40 mg orally thrice weekly, cyclophosphamide, 50 mg daily, and capecitabine, 500 mg thrice daily, collectively known as the VEX regimen. The study exclusively enrolled previously untreated patients with metastatic triple-negative breast cancer. A total of 25 patients participated in this study, leading to notable results. The objective response rate was 27%, and the clinical benefit rate was 50%. The overall survival demonstrated a noteworthy median of 18.4 months. Commonly observed grade 1 to 2 adverse effects included nausea, diarrhea, leuko/neutropenia, and reversible liver enzyme alterations. Notably, grade 3 events, such as hand and foot syndrome, occurred in only 9% of cases. In summary, the VEX regimen showcased substantial activity and commendable tolerability, as the primary therapeutic approach for a specific subset of metastatic breast cancer patients, afflicted with triple-negative disease. Metronomic chemotherapy was also explored in the context of targeted therapy. In this scenario, the researchers considered the potential benefits of incorporating a vascular endothelial growth factor (VEGF) inhibitor, such as bevacizumab, to enhance metronomic chemotherapy for previously treated metastatic breast cancer patients. Patients who had become refractory to anthracycline and taxane treatments were administered cyclophosphamide at a daily dose of 50 mg orally, methotrexate at 1 mg/kg intravenously every 14 days, and bevacizumab at 10 mg/kg intravenously every 14 days. In cases of HER2 overexpressing tumors, trastuzumab was added to the treatment regimen. Following a median follow-up period of 7.7 months, the study yielded promising results. The response rates indicated partial response in 31.8% of patients, while 31.8% experienced stable disease. Overall, clinical benefit was observed in 63.6% of cases. Median progression-free survival reached 7.5 months, with an overall survival of 13.6 months. Importantly, adverse effects were mild, further supporting the viability of the combination of bevacizumab and metronomic-based chemotherapy. This approach proved effective, well tolerated, and provided clinical benefit, particularly among heavily treated metastatic breast cancer patients. Let's now explore metronomic regimens that involve slightly higher doses in breast cancer treatment. In the first study, doctors employed a metronomic-based chemohormonal approach, combining cyclophosphamide with megestrol. This regimen was administered to 29 patients, resulting in an objective response rate, ORR, of approximately 31.0%. In another study, an all-oral regimen was utilized. This regimen included cyclophosphamide, at a daily dose of 65 mg/m2 on days 1 to 14, along with capecitabine, at 1000 mg/m2 twice daily on days 1 to 14, with treatment cycles repeating every 28 days. A total of 68 previously treated patients were assessed, and after a median follow-up of 26 months, a clinical benefit, CB, was observed in approximately 53% of these patients. It's important to note that only 5% of patients experienced grade 4 toxicity, indicating manageable side effects. In a similar vein, a third study employed a regimen comprising cyclophosphamide, at 33 mg/m2 twice daily on days 1 to 14, alongside capecitabine, at 828 mg/m2 twice daily, with treatment cycles repeating every 3 weeks. This approach yielded a clinical benefit rate of approximately 57.8%, and notably, there were no grade 4 toxicities reported. In all 3 studies, these metronomic regimens demonstrated reasonable responses and clinical benefits, with minimal toxicity. These findings hold promise for breast cancer patients, and highlight the potential of such treatments in the field of oncology. Let's turn our attention to another intriguing study in the field of metastatic breast cancer. This study focuses on the use of metronomic chemotherapy, combined with aromatase inhibitors, or AIs, in treating hormone receptor-positive advanced breast cancer. Endocrine therapy is a key treatment for this type of cancer. Yet, the effectiveness of combining this therapy with chemotherapy remains a subject of ongoing research. The study in question aimed to shed light on this, by examining the clinical efficacy of combining AIs with metronomic capecitabine. The researchers conducted a retrospective analysis of 407 patients, all diagnosed with hormone receptor-positive advanced breast cancer. They divided these patients into two distinct groups. The first group, comprising 305 patients, received only AIs. In contrast, the second group, with 102 patients, was treated with both AIs and capecitabine as their first-line treatment. Capecitabine was administered at 500 mg 3 times daily in a metronomic fashion. The primary focus here was on progression-free survival, an essential indicator in cancer treatment effectiveness. Moving on to the results, the study found some compelling data. Over a median follow-up period of 47 months, with a range from 3 to 119 months, the outcomes between the two groups showed notable differences. The median progression-free survival in the group receiving combination therapy was significantly longer, 22 months, compared to just 14 months in the group receiving only AIs. Furthermore, the overall survival was also markedly better in the combination group, at 66 months versus 49 months in the AI-only group. To conclude, the study presents strong evidence that the combination of AIs and metronomic capecitabine significantly improves both progression-free survival and overall survival in patients with hormone receptor-positive advanced breast cancer. These findings suggest that integrating metronomic chemotherapy with endocrine therapy could be a more effective approach than endocrine therapy alone, offering a potential new direction in treating this challenging disease. Now, let's explore the results of a significant study in breast cancer treatment, specifically focusing on metronomic chemotherapy, as a presurgical, or neoadjuvant therapy. This study, a phase 2 trial, was conducted by Dr. Giuseppe Cancello and colleagues from the European Institute of Oncology. Triple-negative breast cancers exhibit aggressive behavior and lack targeted therapies. This reality drives the search for new treatments. Dr. Cancello's study examined the effectiveness and safety of a neoadjuvant regimen based on metronomic principles. This regimen, known as ECF, combines epidoxorubicin, cisplatin, and low-dose 5-fluorouracil, followed by paclitaxel and metronomic oral cyclophosphamide. The study group comprised patients with HER2-negative breast cancer, specifically those with low levels of estrogen and progesterone receptors. In this trial, 34 patients participated. Remarkably, 91% of them, equating to 31 patients, responded positively to the treatment. Of these, 56%, or 19 patients, achieved a complete pathologic response, PCR. Stable disease was observed in 3 patients, and none showed disease progression. The study also carefully monitored adverse effects. In terms of serious hematologic side effects, these were relatively low: leukopenia in 9% of patients, and anemia in 3%. Only one patient experienced a significant non-hematologic toxicity, namely stomatitis. Compared to the current Keynote 522 trial, which showed that adding pembrolizumab improved PCR rates from 51.2% to 64.8%, this comparison is intriguing. It suggests that the metronomic approach can achieve PCR rates comparable to those of modern immunotherapy. This leads to an interesting proposition: future trials might investigate the combination of metronomic chemotherapy with pembrolizumab for potentially better outcomes. In summary, the study concludes that the ECF regimen, followed by weekly paclitaxel and metronomic cyclophosphamide, is highly effective. It results in high PCR rates, and is associated with a low toxicity profile. These findings offer a promising direction for treating challenging cases of breast cancer. Let's now examine a similar study conducted by Dr. Masuda in Japan, which yielded comparable results to the previous trial we discussed. Dr. Masuda's research also focused on preoperative chemotherapy in patients with triple-negative breast cancer. The study explored a regimen of metronomic paclitaxel, cyclophosphamide, and capecitabine, abbreviated as MPCX, followed by 5-fluorouracil, epirubicin, and cyclophosphamide (FEC). In this study, 40 primary TNBC patients received 4 cycles of metronomic paclitaxel, administered at 80 mg per meter 2, weekly, cyclophosphamide, 50 mg daily, and capecitabine, 1,200 mg per meter 2, daily. This regimen was then followed by 4 cycles of 5-FU, 500 mg per meter 2, epirubicin, 100 mg per meter 2, and cyclophosphamide, 500 mg per meter 2, every 3 weeks. M2 means the body surface area, BSA, in square meters. The results of Dr. Masuda's study were notable. The complete pathologic response, PCR, rate was 54.5%. Additionally, the overall clinical response rate was high at 90.0%. Regarding safety, the study reported grade 3 to 4 adverse events, which included neutropenia in 35% of the patients and hand-foot syndrome in 8%. In conclusion, Dr. Masuda's study found that the metronomic PCX regimen followed by FEC chemotherapy was associated with a high PCR rate and relatively low toxicity in TNBC patients. These findings further reinforce the potential of metronomic chemotherapy regimens in the treatment of this challenging cancer type. Ixabepilone is a microtubule stabilizer, approved for use on its own, or in combination with capecitabine. It's intended for patients with metastatic breast cancer, who have demonstrated resistance to anthracyclines and taxanes. This drug is a semisynthetic analog of ipothalone B, with microtubule inhibitory activity. What makes ixabepilone especially intriguing is its ability to bypass common resistance mechanisms, which is why it may be a preferred choice for patients with recurrent disease. Dr. Fountsilas, from Aristotle University in Greece, conducted a randomized non-comparative phase 2 study to explore the activity and safety of 2 different ixabepilone schedules as first-line chemotherapy for metastatic breast cancer. In this study, 64 patients were divided into 2 groups. Group A received ixabepilone at a dose of 40 mg per square meter every 3 weeks, while Group B received ixabepilone at a dose of 20 mg per square meter on days 1, 8, and 15 every 4 weeks. The primary endpoint of the study was the overall response rate. Group A achieved a 47% response rate, while Group B had an even better response rate of 50%. After a median follow-up of 22.7 months, the median progression-free survival was 9 months in Group A, and 12 months in Group B. Median survival was 26 months in Group A, and it was not reached in Group B. It appears weekly treatments are superior to every 3 weeks treatment, although this is a non-comparative study. Now, let's talk about safety. The most common severe adverse events observed were neutropenia, 32% in Group A, and 23% in Group B. Metabolic disturbances, 29% in Group A, and 27% in Group B. And sensory neuropathy, 12% in Group A and 27% in Group B. In conclusion, ixabepilone demonstrated a manageable safety profile in both the 3 weekly and weekly schedules, with fewer side effects observed in the weekly treatment. This opens up exciting possibilities for improving treatment outcomes for patients with metastatic breast cancer. Metronomic chemotherapy has also been examined in the adjuvant setting, which is to say, as a preventative treatment in triple-negative breast cancer, TNBC. A noteworthy study in this domain was a phase 3 trial, led by Dr. Khalid Nasser from Egypt. Patients in this trial received adjuvant chemotherapy, comprising FEC 100, a regimen consisting of 5-fluorouracil, at 500 mg per square meter of body surface area, epirubicin at 100 mg per square meter of BSA, and cyclophosphamide at 500 mg per square meter of BSA on the first day. This regimen was administered for 3 cycles, followed by docetaxel at 80 mg per square meter of BSA, and carboplatin with an area under the curve, AUC, of 5 for an additional 3 cycles. For those for whom it was deemed necessary, postoperative radiotherapy was administered. This was succeeded by maintenance metronomic chemotherapy. For the maintenance phase, patients were given oral cyclophosphamide at 50 mg per day, along with methotrexate at 2.5 mg, taken twice daily on the first and second days of each week. These cycles were repeated every 28 days, and continued until either toxicity, disease recurrence, or the completion of 1 year. A total of 158 patients were involved in the study, divided into 2 groups, with 78 in Group 1 and 80 in Group 2. The mean age among these patients was 46 years. When comparing the outcomes, the median disease-free survival, DFS, for Groups 1 and 2 was 28 and 24 months, respectively, while the median overall survival, OS, for the 2 groups was 37 and 29 months, respectively. During the follow-up, the overall rates of distant metastasis recurrence were 26% for Group 1 and 37% for Group 2. Notably, both groups tolerated the treatment protocol with only mild toxicity profiles. In conclusion, the extended adjuvant metronomic chemotherapy regimen led to a significant improvement in survival, and was well tolerated by patients. These findings underscore the potential benefits of metronomic chemotherapy as a maintenance therapy in TNBC. In a study conducted in Italy, Dr. Francesca De Iulis examined the use of low-dose oral vinorelbine on a metronome schedule in elderly breast cancer patients with metastatic breast cancer, MBC. The study involved 32 patients with a median age of 76 years. These patients were administered oral vinorelbine at a dose of 30 mg, with 1 day on and 1 day off, until either disease progression, or the occurrence of unacceptable levels of toxicity. The study revealed a clinical benefit of 50%. The metronomic oral administration of vinorelbine, with its intermittent on and off schedule, proved to be well tolerated and safe in this specific elderly patient population. Furthermore, this approach enhanced patient adherence to the treatment regimen. Notably, there were no reported instances of grade 3 or 4 adverse events. In conclusion, the study's findings suggest that metronomic vinorelbine may hold promise as a potential treatment option for elderly breast cancer patients. Its use could potentially reduce adverse effects, and improve the overall quality of life for these individuals. VICTOR-6 study is a multi-center Italian retrospective study. It collected data on metronomic chemotherapy in patients with metastatic breast carcinoma treated between 2011 and 2016. Metronomic chemotherapy regimen was vinorelbine-based, cyclophosphamide-based and capecitabine-based combinations. A total of 112 patients were part of this study. Upon commencing metronomic chemotherapy, the median age of the patients was 81 years, with 33% of them selecting metronomic chemotherapy as their first-line treatment choice. The study found an overall response rate of 27.9%, and a disease control rate of 79.3%. Median progression-free survival ranged from 7.6 to 9.1 months, while overall survival ranged between 14.1 and 18.5 months. The most significant observed toxicity was hematological, affecting 24.1% of patients. Severe toxicity rates varied, with skin toxicity at 0.9% and hematological toxicity at 8%. In summary, this extensive study on metronomic chemotherapy in elderly patients with metastatic breast carcinoma offers valuable insights for further exploration in this specific subgroup of frail patients. Dr. Giannini, from the Department of Oncology at the University of Turin in Italy, conducted a retrospective analysis of 110 patients who had previously undergone treatment for metastatic breast cancer. These patients were administered oral etoposide at a low dose of 50 mg per day for 20 days within 28-day cycles. The median number of prior chemotherapy lines was 5, with tumor response and median overall survival rates at 6.4% and 10.6 months, respectively. Interestingly, etoposide's effectiveness was not influenced by the number of previous treatments, or the type of metastatic involvement. Importantly, oral etoposide was well tolerated, with only 2 patients discontinuing therapy due to toxicity. In this extensive analysis conducted at a single institution, the use of oral etoposide proved to be a valuable and safe option for patients with pretreated metastatic breast cancer. It may be considered as a treatment choice for patients who have not responded to other approaches, but are still suitable for chemotherapy. Metastatic breast cancer is a complex and diverse disease. It offers specific treatment targets, allowing for a gradual, step-by-step approach to enhance survival. In this context, metronomic treatments have received extensive research attention. In the metastatic setting, for tumors expressing hormone receptors, several treatment options have demonstrated their efficacy. These include weekly paclitaxel, oral vinorelbine, capecitabine, and ixabepilone, each with its distinct set of side effects to be considered. Now, when addressing triple-negative tumors, the standard approach has become the use of capecitabine. It is often administered after the neoadjuvant setting for patients who still have residual disease. This strategy holds promise in improving treatment outcomes. For heavily pretreated patients seeking palliative care, oral cyclophosphamide and etoposide have been employed. These drugs may be used either individually or alternated to offer relief and enhance the quality of life.